See here. So the first specimen is coming from a 51-year-old male. This is a urine cytology specimen. So the patient received renal transplantation before. So given the history, usually the urine cytology is for screening if there is potential polyoma virus infection. So for the normal urine cytology, usually we will see some urothelial cells, and these cells looks more like intermediate cells. And sometimes, if we are able to identify some umbrella cell, usually the cells are much bigger, maintain a low NC ratio, and sometimes with multinucleation, such as this one. So this one looks more like a normal umbrella cell. So we have some intermediate cell umbrella cell. So we just need to screen whether they are any cells that we would call decoy cells. So for the decoy cells, usually it will show increased NC ratio. So on low power, usually it will look like it's a dark, like a big cells over there. So polyoma virus is an opportunistic infection. So the virus particle will fill up the nucleus. So you will see there are some ground glass appearance, some condensation of the chromatin at the periphery of the nuclear membrane. And usually the cell will show increased NC ratio. And sometimes with what we call a comet sign, that it will have an eccentric nucleus and with cytoplasmic tail. So these looks like a comet cells, enlarged nucleus, increased NC ratio. But when you go to higher power, the chromatin pattern is actually more ground glass. So because it's an opportunistic infection, usually you would expect to see more than one cells. So for these cluster, it's more hyperchromatic. But when you go to higher power, unlike the high-grade urothelial carcinoma, the chromatin pattern is totally smashed instead of like a coarse chromatin. So it's a ground glass, like a very homogeneous and smashed pattern. It can have a darker staining. So these also looks like polyoma virus infection. So because of the high NC ratio and hyperchromasia, we call this decoy cell because it mimicked the high-grade urothelial carcinoma cells. But due to the patient's history and the cytomorphologic pattern, this is negative for high-grade urothelial carcinoma, but positive for polyoma virus infection. So this is the viral inclusion that you can see in the nucleus. Let's move to some pleura effusion specimen. This is from a 69-year-old female. Just on low power, you can already appreciate that there are a lot of big cells with dark nucleus, and a lot of them were arranged in a tight, like a three-dimensional architecture. So on low power, this looks like a positive specimen. So we just need to go to higher power to confirm the cytomorphology. So these cells has a very typical cytomorphological feature of adenocarcinoma. So we see increased size of the nucleus. The chromatin pattern is vesicular. The nucleoli are prominent. The size and shape seems to be pleomorphic, and it arranged in a very tight three-dimensional glandular architecture. In the cytoplasm, we do see some vacuolation, and the nucleus is often eccentric. So these are typical cytomorphologic feature of adenocarcinoma. So the patient do have a history of lung adenocarcinoma. This has been proven to be TTF1 positive. So this is consistent with the persistent or recurrence of the disease. So if you take a look of the cell block preparation, it shows very similar morphological pattern. For the cell block of the effusion, if they are adenocarcinoma cluster, usually around the cluster there will be an artificial cleaving space. So this is actually a sign suggests that these cluster of cells are more likely to be adenocarcinoma than reactive mesothelial cells. So next specimen, also lung cancer. So we have a lot of these type of specimen. History of lung cancer, low power. It was not that striking as the prior specimen, but just on low power, you can still identify tight cluster, darker staining, and more like a bigger cell, three-dimensional architecture. So we just need to go to high power to confirm. So indeed, these cells harbor very similar cytomorphologic pattern. Large nuclear vesicular chromatin, prominent nucleoli, three-dimensional arrangement, and the bubbly cytoplasm. So this is consistent with metastatic adenocarcinoma. So for the cell block preparation, it also shows similar feature with less tumor cells. But here you can still appreciate these clusters do show artificial cleft around the tumor cluster, and here we do see very bizarre like mitosis. So this is positive for adenocarcinoma. Let's move to finding the aspiration. So this is coming from a 53-year-old female, and this is coming from lung. We have the direct smear for this case. So it is not much, only like a small area showing these cellular elements. So on low power, you can already appreciate that in the background, it is highly necrotic. So most of the specimens show these necrotic debris. However, we still can appreciate some atypical cells, mostly with naked nucleus without cytoplasm. So some of the cells are in cluster. So for the primary lung cancer, usually you won't see these prominent necrosis pattern. So if we see this necrotic pattern, we will suspect that the patient may have the metastasis. And this type of very dirty prominent necrosis is most commonly that you can see in metastatic colorectal cancer. However, for the cytomorphology here, these cells in the smaller cluster demonstrate like a very rounded nucleus instead of like an elongated, like a palisading type of nucleus that we can see in the colorectal cancer. So we go back to the history. The patient actually have breast cancer. So this is most likely to be metastatic breast cancer. instead of primary lung cancer. So we would sign out the case as a non-small cell carcinoma, and we will address that the patient do have a history of breast cancer. The patient also had the concurrent biopsy, so they will do the lineage marker on the biopsy specimen. So the next specimen is a thyroid fine needle aspiration coming from a 63-year-old female. So on low power, we don't see a lot of colloid. The background is very, very clean, and the cellularity is relatively scant. So we start to appreciate there are some smaller, tight cluster of cells. So we can go to higher power to check the morphology. So the cells are mostly rounded with a uniform size. The chromatin pattern is condensed, not showing this ground glass pattern. The most striking feature is the arrangement. So we do appreciate they are microfollicles. So it looks like aggregates of microfollicles. So when we encounter these type of specimen, if the background show no colloid and the majority of the specimen show this microfollicular arrangement, we do not see any nuclear feature of PTC. So the diagnosis is depend on the cellularity. If the cellularity is high, and you can also see, for example, larger fragments with fibrovascular stroma, and it is likely to be a follicular neoplasm. So in that situation, we will sign it out as TBS4, suspicious for follicular neoplasm. And if we only have very scant, like a cellular component such as this one, but the background doesn't look like it is a hyperplastic nodule because there's no colloid, and the arrangement are predominantly microfollicular. We would call these AUS with architecture atypia. So in the new Bethesda system, they only recommend that we do subclassification for whether there is nuclear atypia or not. But here we still use the more detailed like subclassification, just try to help the clinician to navigate the nature of these indeterminate nodule. So we will call these with architecture atypia. Based on our institutional analysis, the risk of malignancy for AUS with architecture atypia is less than 15%. But if it's with a cytologic atypia, the risk of malignancy is higher than 50%. So it is a very striking differences. 我记得好像有一个乳癌转移的片子是 effusion， 是留着染色嘛？还是？所以 OK， 好。So we have a lot of positive pap smear today. Oh. Okay. 61-year-old female who had a history of HPV high-risk infection, and we asked us smear at the hospital in China. So he came back to Taiwan and have a second like a smear here. So 61, so relatively like a maybe already postmenopausal. So on low power, we don't see a lot of superficial cell. Mostly intermediate cell. So along the smearing direction, we have these dots. And when we go to higher power, so we can appreciate that we do have some cells with slightly increase of NC ratio and a slightly darker staining of the nucleus. The size of the nucleus is not particularly increased, and there are some like a very vague halo over here, so a vague collocytic feature, such as this here. So it's based on the morphologic pattern, I think we can only call these ascus, right? Because there is no like a unequivocal collocytic cells, and the nucleus is not particularly hyperchromatic, just a slightly increase of NC ratio, slightly darker staining. So this is our ascus. So the case is signed out as ascus. So this is one situation that we call the case ascus. The other situation is often very annoying, very troublesome. This is coming from a 55-year-old female, so young, but she had a history of endometrial cancer, and she already received total hysterectomy long time ago. It's more than 10 years ago. And more than 20 years ago. It's weird. She's only 45. Unusual, unfortunate for this patient. So basically, the patient has been artificial, like a iatrogenic postmenopausal for a long time. So here, this is an atrophic smear, right? So we do see more like a cohesive cluster instead of individual cells. In the background, there are a lot of cells with naked nucleus. So this is an atrophic pattern. So the patient has been in our hospital for a while. So she had like 4 or 5 times pap smear through the interval of the recent 5 years. So on low power, first thing it's a little bit unusual is that it seems to be a little bit bloody. The specimen is a little bit bloody. So bloody specimen, you usually need to pay more attention because they may be some invasive lesion. So atrophic smear is one of the nightmare in the pap smear because you can see a lot of these like a very dark staining cells, high NC ratio. But majority of them, these are actually parabasal cell. So for the atrophy, we usually will see large fragment of parabasal cells with these darker nuclear increased NC ratio. So if the entire specimen looks like this, usually we will be reassured that it's more likely to be atrophic smear instead of a precursor lesion. So the distribution of the smear is very important. As we know, if the patient had a seal lesion, it's usually a focal lesion. So it would presented along the smearing direction. It won't be throughout the entire smear. Something unusual about this specimen is that they are areas that we start to identify some more mature keratinized cells with nuclear atypia. And some cell even showing a little bit like a spindling. So when we start to see like a keratinized cells with nuclear atypia, we should be a little bit more alert. If these are all parabasal cells, these are fine. Although it looks scary, it looks like everything looks like a high CO here. But when you go to higher power, the chromatin pattern is delicate, homogeneous, right? It is not coarse chromatin. And the pattern is throughout the entire smear. And then we should be reassured that these are atrophy pattern. But if we start to see some more keratinized cell with apparent nuclear atypia, I think we need to be a little bit worried. So the patient do had a smear like 2 years ago, and we also called these ASCAs. At that time, I think the clinician didn't do more survey, and the lesion was not as prominent as it is this year. So for these atrophic specimen, due to the keratinized cells with nuclear atypia and more than usual like blood in the background, so I think we are going to call these ASCAs. So this is why we use ASCAs in a different scenario, that when we see the atrophic smear, but we do see some like a striking nuclear atypia, particularly for the superficial cells, then we can still use the category ASCAs. I just want to show you the patient's prior smear 2 years ago. So this is from 2 years ago. Basically very similar pattern in the background. So aggregates of larger fragments of high NC ratio cells, but with homogeneous chromatin pattern in the background, a lot of naked nucleus. So this looks like an atrophic smear. And in this smear, they were very scant. Very scant superficial keratinized cells. So a little bit blood as well. So at that time, we also call these ASCAs specimen. Yeah, but this year it seems to be more of these like a keratinized atypical cells. So for these specimen, we will call these ASCAs as well. So then we move to specimen that we call ASCAs cannot exclude high C or ASCAs high. 67-year-old female, no history. So basically also postmenopausal, so you don't see a lot of superficial cell. You actually see quite some inflammation in the background. So a little bit like atrophic vaginitis type of pattern. So in this specimen, we start to identify a few clusters showing these like degenerative type of the feature, but with increased NC ratio and dark staining nucleus. Due to the degeneration, it is you won't be able to see the chromatin pattern very clearly. But because of these spindle shape, these are still more likely to be squamous epithelium. So whenever we see a cluster of cell with atypia, the first thing that we need to confirm is whether this is a squamous epithelium, or this is a glandular lesion, or this is coming from elsewhere. So for this specimen, we only have these two clusters of cells with more like a spindly and with a degeneration like a pycnotic type of nuclear change, but very dark. The NC ratio is increased and it is a little bit spindly. So for this case, we will use ASCAs cannot exclude high CO for these two clusters. So this is how we are going to sign out the case. So this is our ASCAs high. So next, a 49-year-old female. So she had the past history of an Oscar smear and a positive HPV other type. So this is a repeat smear for screening, 49-year-old, so relatively young, and you can see a lot of superficial cells. The background is very clean. So in this smear, usually we will only look for the precursor. So I just want to show you that what is that we call the smearing pattern, that if you identify some atypical cluster that is indefinite for diagnosis, just look around along the smear, then you can find some more. So for this case, so I would say for the high CO, it's usually more difficult to screen because the cells are very small, smaller than the low CO. And it can mimic some inflammation, some histiocytes. So these cluster, we do see a little bit increase of the size of the nuclear comparing to, usually our reference cell is the intermediate cell, not the superficial cell. So we compare with the size of the nucleus of the intermediate cells. Do we see on the screen? Yeah. Of the intermediate cell here. So these seems to be a little bit bigger, right? But the cytoplasm is a little bit bubbly, so it's a little bit uncertain whether this is actually coming from the endometrium or this is a squamous cell. But the nucleus does show a little bit like hyperchromasia and a coarse chromatin. So just like what I say, when we identify, so we call this hyperchromatic crowded group. First of all, we need to determine whether these squamous or these glandular or these coming from the endometrium, etc. If we are uncertain based on only a single cluster, we just move around. So then we move around the smear. So this is relatively difficult to screen, so our screener is doing a good job that identify some of these like darker cells with higher NC ratio hiding in the sea of superficial cells. So we all start to find like similar cells that we saw. So here is another one. And here is another one. So the feature here are a few more. So the feature of this cell, it shows like a little bit like a degenerative pattern, but it is just too dark, a little bit difficult to determine whether this is actually coming from the endometrium. If it is coming from the endometrium, usually we will have a more like an endometrial debris type of background, but we do not see here. However, we are also not very certain that these are truly squamous cells. I mean, if these are squamous cells, these are likely high CO, right? So we are calling these Ascus high. So this is also our Ascus high. And we do not see more of these atypical cells throughout the entire specimen. So this is what we call Ascus high. So for the low CO, so usually we will have more cells. So these need to be to do the cover sleek again, okay? So we have superficial cell, very dark staining, and a lot of them. And throughout the smearing direction, we can find some more. So here we have binucleation, dark staining, sort of like a coilocytic feature. And there are some area with a more like a prominent coilocytic feature, such as this. And the amount of lesional cells are plenty. So for this case, we just call these low CL. So this is our low CL. We can directly call these low CL. Finally, a 55-year-old female who has been followed in our hospital for breast cancer for almost 2 years. And this is her very first smear in our hospital. On low power, we do not see any normal squamous cells at all. And we see the background seems to be necrotic. We have a lot of these spindle, typical looking cells. So this is a very typical squamous cell carcinoma. So nowadays, when we see squamous cell carcinoma, it's usually in those who never screen. So this is a typical case, 51-year-old, still young. And she has been followed in this hospital for more than 2 years with oncology, but the oncology never asked her to do a cervical smear for cervical cancer screening. And one day, she got the chance to do it, and it's invasive squamous cell carcinoma. Yeah, so screening is very important, and most of the situation nowadays that we see squamous cell carcinoma is for patients who never screen. And it is not because of there's no resources for her. And she just came to our hospital like every month. But still, she failed to join the screening program. And then it developed an invasive cancer. Yeah, it's more lethal than the breast cancer nowadays. So this is positive for a squamous cell carcinoma. So that's for all the case today.
Thank you.
Thank you.